Well, it's 9:30. I don't see Representative Edwards, who's trying to connect on the audio. So 9:36, and I'll call the meeting to order. This is the Prescription Drug Affordability Board. It's now October 2nd. In regards to the introductions, my name is Gary Merchant, Representative Gary Merchant. I represent Sullivan County District 6 and chair of the board. On to my left.
Former state senator Tom Sherman, also a physician, and I have been on the board since its inception.
Bob Woodward, alternative member, professor emeritus at UNH.
And on the Zoom, we have two. I think I see President Edwards and Senator Rosenwald.
Yeah, hi, good morning.
And
Wanted-
Cindy's muted.
You want to introduce yourself?
Cindy Rosenwald, Senate District 13. I'm an don't know if I'm being promoted to a regular member today.
Yes, you will be promoted to a regular member today to the Senate side. And I'm also going to promote Bob Woodward on the House side to have a quorum.
Have to hop off at 10 o'clock for about a half hour.
Yeah, thank you for that. For the group here today, agenda review, what we propose today is to go through some general updates, review and approve the minutes for the August meeting, sort of a draft outline of what's the annual report going to look like, have a presentation by Dr. Prima, and also public comments, discuss future dates of the board, and we'll go into a non-public session. And at that point in time, after the non-public session, we'll come out to adjourn in public. So those who are members of the public, once we go into the non-public session, there'll be no business being conducted afterwards except take a vote on sealing the minutes in the public session and then to adjourn the meeting. Is there any change on the agenda? If not, I'll go through updates. We have now, as of September 4th, we have two new members of the board. One is a board member, a voting member. One is Representative Jess Edwards. He is replacing Representative Murphy. And also to let people know, Dr. Nagel, Representative Nagel, has also been appointed as an alternate. As the Senate, we have actually two alternates, both in the Senate as well as in the House, as well as in the governorship. So Dr. Nagel, Representative Nagel will be the alternate, as well as Dr. Woodward. On the disappointment side, with regret, I have received a letter from Dr. Marsh, Representative the Honorable Bill Marsh. He has resigned from the board due to for conflicts of time with his family. Some things are going on personally. He wanted to let me know that he would not have the time to put into being on the board to do it correctly. So I will accept his resignation with regret, but I also want to say thank you for what he has done for the board. He's very instrumental in a lot of things that we were doing. In regards to the August minutes, I would like to have a motion to approve the minutes. Hey, Todd.
So move.
And I'll second the minutes.
Second,
Thank you, Senator. All those in favor say aye.
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 Any
Abstain because I wasn't here.
Dr. Sherman's going to abstain. In regards to the annual report, I put together with Dr. Woodward and myself. It's pretty much a draft he created. I want to say thank you for the work you put into this. It's a lot of work, and I wanted to recognize that. You have an outline of what the report will look like, the executive summary, table of contents, the introductions, and so forth. And what we'll do is go through this. I did talk to Dr. Ezzy in regards to number 6. He's in the process of trying to work with me on categorizing medical expenditures. We talked about way back when that in drug expense, there's 2 basic buckets. One is on the pharmacy benefit side, which goes to most of the time in pharmacies, and one is on the medical benefit side, which goes to the medical benefit side. Dr. Woodward is actually handling the pharmacy benefit side, and Dr. Aziz is going to be handling the medical expense side. And they go through summaries and conclusions. So what I wanted to do today was just
May I ask a question? So I've submitted that historic, and you've shared the historical piece. There are a bunch of graphs, and I apologize for the kind of academic stuff, but there's some questions there at the end. In particular, the last 2 graphs, there's some strangeness associated with that. Medicaid in New Hampshire seems to have deviated from Medicare or from Medicaid nationally, and the prescription drug has a big blip in it. I would welcome comments from anybody on the board or outside of the board about what is going on.
Can I ask a question of clarification?
Sure.
These are black and white, so,
They're not as I produced them.
no, I'm just wondering which line is which on figure 5.
The bottom line is New Hampshire.
Oh, okay. And on the last one,
That is
That's
just
all,
the
that's just
state.
one line,
Yeah,
yeah.
right.
in regards to, I think you talked about the Medicaid prescription expenditures compared to the national average. I think we had a conversation with Mr. Lippin, and there was some concerns about how the data would have included the rebates and so forth in there or not. We may want to circle back with him to help guide us in that,
I
or
would,
somebody.
yes, I would be glad to open that conversation. That said, I am disappointed not having received any information from them about what the budgets were, and I don't know the status of that, but another phone call to ask him to comment on this, I think would be very appropriate.
I will make a phone call and see if we can set up a time with either himself or someone on the staff with the analyst, begin to understand it.
Yes.
Okay, that'll be my takeaway.
Yeah, they're in color on that.
right?
Is there any other comments from the members that are remote?
Todd's on.
Todd? No. Representative Edwards? Or Senator?
I'm good, thank you. I'm gonna do a lot of listening since this is my first meeting.
Oh, all right. Thanks, Senator. We're going through the outline of the annual report right now in the packet. Do you want to introduce who you are, so people?
Good morning, Senator Darrell Adams. I represent District 22, communities of Pelham, Salem, Axon, and Plastow.
Thank you. So in the report, there'll be an executive summary, which I just put together here for people to have to look at. Again, it's just summarizing what we have done, what we're trying to do and so forth. And then at the very end, what I wanted to talk about is more strategy wise, is talk about I want to be sure I'm capturing everything. Goals for 2024 going forward, and also what are the strategies to reduce drug costs. This is my. You can see this one.
I'm sorry.
This one here. Thank you. So I wanted to be sure I'm capturing what the board is looking for as goals for next year. And then at the same time, what are some of the strategies we want to explore next year? So at this point in time, the ones I identified, I thought were kind of relevant to get this discussion going was the question of the executive director, of course, is to hire and onboard them. We have a redundancy report that we have to create with the insurance department. We have to establish the advisory council. Think past legislation supporting board objectives, whatever those objectives are. Recruit board members to replace members that are coming off the board. Implement strategies to reduce drug costs, which is one below. Publish the report. And then explore grant funding. Is there anything else board members think we should have as a goal? As Senator Rosenwald?
Yes, I'm wondering in number 6, if we're really talking about drug costs or drug expenditures.
Yeah.
Yeah, probably drug expenditures is a better word.
So, yeah.
And
On-
again, it's among public. Right,
Public.
isn't that our statutory charge?
Yes,
Yeah.
it is. We catch. If you wish to speak, please do me a favor if you're on remote to raise your hand so I can recognize you.
I'm having a truck. Oh, there it is.
All right. Senators Rosenwald, are you all set with? Is there any other comments you would like to make? Or she's on mute. Representative Edwards.
I have a couple. I'll start with 6 and then go to 4. Can you hear me okay?
We can hear you.
Okay, so on 6, I'm curious about the use of the word implement strategies. I don't think the RSA gives us the authority as a board to implement strategies. I believe the legislation says we are to recommend strategies. So the word implementation is an action term that I don't think is within our scope. And I can go to point 4 now or take your comments on my comment.
Yep. I think your comment on number 6 was well said, and it should be recommend, not implement.
Okay,
Sure,
thank
I
you.
concur.
And then on 4, I'm just curious about the timing on this because the House, the Senate is still able to do it, but the House, we passed our window for submitting legislation to OLS for drafting. So if there's any legislation that the board is looking at, it would have to go through the House. And so it just, or excuse me, the Senate. And so I'm just curious if that's an achievable goal to pass the legislation, given that, it isn't clear that we have any to draft.
I can just speak on that. If there's any legislation that they wish to propose, whether I support it or not, I'll still as a courtesy file it. And, I think, I'm sure my other colleague in the Senate will do the same.
Right. Good. Thank you, Senator.
Okay, so do we have draft legislation or at least draft concepts that we, passing legislation is one thing, but it's more important to really know what we're trying to achieve.
One of the things I think we should try to achieve is that the current executive director way it's written is only valid for 2 years. And I think it's going to be one of the things that you should be looking for is to extend that for a period of time. And then number 2 is the way we fund it. Right now, we're taking taxpayer money out of general fund to try to save the taxpayer money. And to get away from fees, but we're talking to people before, one of the things we have been able to do is what they call split the fee. In other words, if you look at the marriage license is $50 or $75, but only a small amount of that goes to the vital records. The rest of it goes to domestic violence. So there's ways for us to do that and still stay within the constitutional realm of what we're trying to accomplish. So I'm trying to find a way, Representative Edwards, to not use taxpayers' money to try to save taxpayers' money.
Okay, so I'll just exit on my comments about point 4 to just ask you, since you've been doing this so long, whether you think the word pass is appropriate or whether
Introduce.
it's or introduce or develop. Yeah, okay.
I
Very
think
good.
you're-
Thank you.
I think introduce is a better word than pass. because we
Thank
can't
you for
pass it. We can't pass
allowing
it.
me to participate.
Thank you, sir. Is there any other goals that people have that,
I just have one question, I guess, more rather than a goal. Legislation that passed last session really took away our ability to draw data from all the different entities that we are trying to understand costs. I guess since next year looks like it's going to be the first time that we have the capacity to actually look at data and analyze it, we need to, over the next year, assess the adequacy of the data. Because really, the legislation, without us having had the experience of having a full access to the data, the legislation took away that data. So the question is, does the board have enough data to really make recommendations and recommend strategies, or do we need more? So I think that would actually be a legislative recommendation for 2025. So I think I would put in between 5 and 6, assess adequacy of data available to the board to create recommended strategies or something like that. Right now, I think, we are really limited to publicly available data. And that is the huge difference between what we had before and what we have now. So, we can do all the analysis we want, but we don't have the kind of depth of data access that we had prior to that legislation in the last session.
I agree entirely. One sort of refinement on that is that at the moment, we have access to summaries of the Medicaid management information system, not the Medicaid management information itself. And we have access to summaries of, I think, the New Hampshire comprehensive health information system, but not the data itself. Being able to do analyses is severely restricted by having to wait for summaries of data from the two sources. So as you consider access to data, I don't know, and that's, primary data ourselves, it would be a real boon in terms of being able to do analysis. But if that turns out to be impossible, to also see whether there would be some way of having hands-on the data set, even if it were restricted to here in Concord, for example, being able to have hands-on with a fairly convenient access to a machine that is connected would be, I think, critically important to be able to do analysis.
so, Dr. Woodard, I'm hearing two things. One is access to the data, and the other one is the adequacy of the data. They both seem to be playing into.
I agree, it's separate.
Right. The overarching would be the adequacy of the data that we have available in 2024.
Right.
On which to base recommended strategies. When you look at what we had originally wanted to be able to do, it was to be able to look at drug by drug, price points, costs to the state, all of these things. And that, my suspicion is that is gone. The ability to do it at that granular level. So the question is whether without that data, we can make meaningful recommendation. And if we need that data, then in 2025, we might think of a way to acquire that data, whether it's going into CHIS or MMIS, or whether it's going into proprietary, which is what we had the right to do before, but we don't now. And I don't want to, and Representative Edwards, and we've all had this discussion. We don't want to go into levels of confidentiality or proprietary data that we don't need to access. We only want to access what we need. So I think this is an opportunity for us to see if we have adequate access or if we need more to do what we need to do.
Senator Rosenwald? Senator Rosenwald, your hand is up. Did you want to comment?
Yes, I'm gonna have a couple of minutes, but did have a couple of comments, one on relationship of fees to what program. In addition to domestic violence, I think another really good is the LCHIP program. And there are a number of others as well. But I think or Abbas say that, yes, we're in the filing period between the two of us. And Senator, sorry, the audio is not great, but we filing until the 12th.
12th of October.
Yes, and I'll be back.
If I could, between yourself, Senator Rosenwald, and Senator Abbas, possibly talk about some strategies to how to fund the board, because I think it's kind of.
Well, I guess I would just say that we have 2 years of funding. It Representative Edwards thinks, but it may be better to think about mechanism over the next year and then approach it as we did again.
The next budget cycle.
Mhm.
All right.
I mean, maybe he doesn't agree, but
I think that's a great idea. I think for any commission, not speaking just this one, obviously proving its value going forward should be an easy sell. And I think obviously there's a public interest in what we're trying to accomplish here.
And I would just, I think it would be great to have the discussion in front of the board on, once you've come up with ideas on how to do that funding, because as Senator Abbas said, he may or may not agree. We would really love to have unanimity here on how we go forward asking for funding. So that the board can go on block and present their case in the budget year. So rather than just trying to get it through now, I agree with Senator Rosenwald.
And then the other question is going to be on grant funding. I think there's a possibility to explore grant funding. There is, I think, either in private or in public opportunities for us to obtain additional resources. I think what's going on at the federal level and so forth, New Hampshire being a small enough state, we can actually work on things pretty quickly. And it could be sort of a test tube about what we're doing. I think we can reach out to some of our federal delegation and talk to them about the possibility of helping us with additional funding if we need it. All right, we all set with the goals for 2024?
I had my hand up.
Oh, right. Go ahead.
Okay, so I just wanted to follow on. I think there was an implied question from Senator Rosenwald. And I just want to state, since it's my first day with you all, that I totally support and am enthusiastic about the goal of creating price transparency in order to facilitate pricing discipline and better prices for our public payers. I'm totally on board on that. And that any legislation that we propose, I just want to make sure that we're doing something smart, and if that takes more time to develop, then I'm okay with that. I think we should get this right since we're still kind of on the ground floor. And to just another point about grant funding, I believe the legislation also authorized a kind of a gifting account. I'll call it a gifting account for lack of the real word, where we can accept donations from the organizations such as AARP, who really got behind the development of this board and said it was a smart thing to do. I think we should maybe go ask them to contribute now that there's a fund that can accept their donations. We don't need a grant. They could just give us a donation at this point, assuming the account's been set up.
Thank you. It's a good point, Representative Edwards. I just realized something as listening to the conversation. In our rules, do we have a process to receive donations or grants? Or do we have to create rules for that too?
I think we have to create rules for that, because I think we pushed that off, for the time being, because I don't think we wanted to spend a lot of time figuring that one out, but.
So it was one of the things in our goals for next year, we have to write the rules first before we can actually receive the money.
That's my understanding, yes.
And then if I could, just one more observation. I don't share yet the concern of Dr. Sherman and Senator Rosenwald to find other indirect sources of money to fund the PDAB. I think this is a legitimate state function and is as entitled to state funding as any other legitimate state program. So I hear that you guys are interested in that. I just don't get it yet. So thanks.
Just to clarify for the record, did not bring up alternative forms of funding for this other than the state funding. I was talking about data.
I was talking about the issue of alternate funding. I just think that in some ways we're going to the taxpayer and asking the taxpayer to fund something to try to save the taxpayer money. When we look at the marketplace itself, we have ways to assess fees, or how you want to call it, in a way that is not trying to take money out of the taxpayer to save them money. So that's kind of my philosophical belief, is that it doesn't make sense to go to the taxpayer to ask you for money to try to save you money. I'd rather go back into the business community and so forth at that point in time, which is kind of what the fees were all about in the first place. That was my comment, Representative Edwards. It was not Dr. Sherman's comment.
Thank you for the clarification. I stand corrected.
Okay, moving on to number 2, strategies to reduce drug cost. Again, this is going to be one of those things where some things I've identified is we have it coming up at 10 o'clock with Dr. Primuth. But talking about biosimilars, I think right now we had a very robust savings, if you will, in the marketplace. When generic pharmaceuticals came out in the 70s, there was a tremendous amount of pushback from the industry trying to protect their revenue stream, which I totally understand. We overcame it as a society. We overcame it with regulations and laws to allow the pharmacist to basically at that point in time provide generic substitution unless the physician said no otherwise. I think we'll have the same opportunity now with biosimilars. They're running in the thousands of dollars. There are things on the market such as Humira, which costs roughly $33,000 a month, $36,000 a year. There's ones coming into the marketplace now which cost $600 a month, which is a far savings. But if we have within our laws, we don't allow the pharmacist the ability to substitute for the process to get there, patient can't either save that $2,400 per month. So those are the things we look for, is how do we increase the utilization? What are some of the barriers to get there? Are they question of legal? Is it a question of our laws? You know, what are they? I don't really know. Is it also a question about payment methodologies? Because if we're paying somebody based upon the $3,000 drug when one's available for 600, why are we reimbursing a facility for $3,000 when you can buy one at 600? So I think we need to look at the payment methodologies, as again, private payers, and saying, which one are we paying for? Dr. Sitch.
I can, just speaking in general, since some
Yeah.
other states have done this, I don't know what the policy is in New Hampshire. That if there's a prescription written, it is presumed to be for the generic unless it expressly states on there, you know, the name brand or the non-generic. So I don't know if we have a policy like that, but that's how some other states have done it.
On the small molecules, the chemical ones, that's absolutely true. When you get into biosimilars, because they're not really totally 100% equal to each other, there's a different process, and we have in our state law is a process for substitution of biosimilars, but unfortunately, it's not as robust as it could be. I'll give you an example of something, Senator Abbas. If you have Humira, then you have an interchangeable drug here. This is interchangeable. If I have one over here, this is interchangeable, but these two aren't. So I'm trying to figure out what's the science behind it? Is there a reason why we could at not at a point in time say, okay, if this is substitutable with Humira over here, this is substitutable over here, then why are these two substitutable? So to your point, was the physician writes for it, prescriber writes for it, the pharmacist has some leeway to what they can provide to the patient to try to save some money. So that's kind of, but I agree with what you're saying is I think we need to find what the barriers are and then figure out how we can minimize the barriers to maximize the savings.
So are you saying that, you know, when you make the triangle, you know,
Yeah.
the top point is compatible with the bottom two, but the bottom two for some reason don't overchange?
Exactly.
And like a live example of that, or a real world example of that?
Actually, Dr. Primuth can probably do better than I can. But there are two interchangeable drugs with Humira. Okay, so the FDA has approved the interchangeable. So I write for Humira, I can give you A or B. But I write for A, which is the one that's $600, I can't give you the B. I can give you Humira, but I can't go crosswise. And Dr. Primuth, if you could possibly talk about that, it'd be helpful, maybe along your journey. Representative Edwards, you have a question?
I'd like to talk about strategy number 4, aggregation of PBMs. I'm not sure I understand the fundamental economic theory to say that the aggregation of the PBMs, or I think that's another word for consolidation, the consolidation of the PBMs. I'm not sure that that's demonstrated to be an effective strategy to actually reduce drug costs. So
No.
I guess I just want to know more about that.
It's not the aggregation of the PBMs themselves, which is consolidation on the provider side. It's looking for the buyers. We have many multiple entities, I think, within our state that are using various PBMs. So why are we not being smart enough within our own state to pull our resources together to try to come up with a single contract with a PBM on behalf of all of us? We're basically buying a service from a PBM, but if we fragment ourselves in a buying power, we cannot get as much of a squeeze, if you will, for the juice based upon trying to all the people buying PBM services, the public payer side, is why don't we all work together as a co-op and go to one PBM and bid them out?
I think I like the wording that you just closed on a little bit better, Representative Merchant, where you say, organizing public payers into a purchasing co-op. I think if we look at it from what the state action is and is not, we can certainly organize as a co-op, but the aggregation of the PBMs, that term sounds to me like we're interfering with market forces.
No, I totally agree with you saying the word aggregation is probably not the right word to use. It's more to create a buying co-op.
So to follow up on what Representative Edwards said, it might be helpful, since these are proposals. Instead of saying strategies to reduce drug costs, to say strategies to consider in order to reduce drug costs. Because we're not saying these will be the strategies. These are ones that you're proposing we take a look at. And I agree with Representative Edwards that we need to take a closer look at each of these and see if they're appropriate. And maybe a broader way of saying, point 4 would be to, is that, enhancing public payer buying power in relationship to PBMs. And, you know, there may be, we were just on the side, Bob was saying that there may only be one PBM, but how they choose that PBM, how that public payer entity actually selects them, that may be part of the process. And that's what you're talking about, is being smarter in that relationship with the PBM.
Correct.
Okay,
So it's a buying power, plus it's also looking at trying to be sure the public payers that are using PBMs are informed as much as possible, so they're making a wise choice. So it's both the educational part of it, helping them understanding what should they have in contracts.
and then the relationship.
And also the relationship, and at the same time, can we pool our buying power to reduce the cost?
But I think we do, and I agree fully that I think we need to explore all of these once we have data available to see if the data supports moving forward with these.
All right, is there any other strategies to consider to reduce drug costs? I do like the way you reframed it. It's not, it's for us to consider these. Senator Abbas?
I was just hoping to get, I don't know, maybe someone answered it, kind of went, this is my first day hearing here, so let's bear with me. And I don't have a medical background, we'll just leave it at that. But if someone can give me an example, like you mentioned that trying, I'm just trying to get like a real world example of any medication. You don't have to name a brand where, you know, A goes to B, but B can't get you to C. I'm just trying to map that out because I think we might be able to tweak language in existing law to address that without reinventing the wheel. It's true. I just help me understand like when that applies. I kind of get it, but I just want to make sure I get it.
Can I, Dr. Primuth, can you possibly help us out? I know you're not ready to go on with your presentation right now, but this is a very healthy discussion. And if you can possibly help Senator Abbas with my description of Humira, where you have interchangeability from one drug with Humira, another drug with Humira, but the two that are interchangeable with Humira are not interchangeable themselves. Is that?
Yeah, absolutely. Good morning, everybody. Can you hear me okay?
Yes.
Perfect. Thank you. Greg Primuth. So actually the best example that is out there today as the Humira interchangeability, one product is interchangeable today. There will be another product interchangeable in 2024. So today, for Humira, there's actually only one interchangeable product. We'll talk about that during my presentation. But today, for the insulin product Lantus, there are two interchangeable biosimilars. One is called Semglee, and the other one is called Resvoglar. And so if I have a prescription as a pharmacist, I can interchange either Semglee or Resvoglar for Lantus, which are significantly less expensive. But if I have a patient that's on Semglee, I cannot change them to Resvoglar if for some reason I don't have Semglee in stock or the payer changes what they cover. That would require a new prescription, even though they're both interchangeable to the reference product Lantus. Does that make sense?
Thank you, and that's a perfect example. And medically speaking, I understand we're not talking about any patient specific, but is there really any consequence of taking either one of the generics? Would it be a dramatic consequence of that? if you don't mind.
Yeah, as a physician, we almost always will go with a generic unless the patient tries that generic and has either an adverse reaction or it doesn't work as well and doesn't work adequately. So I have had patients where we've gone with a generic and they go back to the brand name because they had either an adverse reaction or they just didn't have the desired outcome. There is no reason, and I think Mr. Primuth or Dr. Primuth would probably agree with this. There is no reason that you can't try those unless there is a contraindication to trying them. So similar to other drugs, you should be able to try them.
Is there any significant risk to the patient by going, because let's say Semglee is not, hope I said that correctly, that's not available. Is there any real adverse risk of the patient taking the other?
No, well, it depends on the drug. There's no you can do a trial of a generic. And if it works, that's great. So if it's biosimilar and equivalent, then unless they have an adverse reaction or a contraindication, it should be appropriate for the pharmacist to substitute it.
Dr. Wood?
I'm the economist on the group, and we've talked about equivalence of the medicine, the efficacy of the medicine. We haven't talked about the difference, price differential. I presume the two biosimilars are cheaper than the brand name, but is there a difference between the price of the two biosimilars?
I don't know, Dr. Freeman?
Yeah, absolutely. Each manufacturer has an ability to price their product in whatever fashion they would choose. The standard sort of SOP among biosimilars is that Resvoglar and Semglee are very comparably priced. When you look at the Humira biosimilars that are out, there's 8 or 9 manufacturers, and they all have a variety of pricing strategies. We'll talk about it. There's a high cost, low cost strategy, essentially. So most of the high cost biosimilars are about 5% less than the brand reference product Humira. And the low cost strategy is a little bit different. I'm sure you all saw the Mark Cuban announcement. And so that company is doing a little bit something different than the others. But it's a unique marketplace with very interesting pricing strategies. But, you know, from a pharmacist point of view, their goal is always to get the patient the lowest cost medication. You know, that's obviously appropriate clinically. So that very often changes occur because of economic reasons for the patients, of course, when the pharmacist has the ability to do so.
Thank you.
You're
Next
welcome.
question.
Yes.
Is there any more questions about the strategy? I think I got the title for strategies to consider to reduce drug costs. I went through my notes here about the aggregation changes to a buying co-op for PBMs with buyer power, and the other one's limited spread pricing. It's available. I think in New Hampshire with Medicaid, we had a specifically spread pricing, by the way, so you understand what that means, is that the insurance company will pay the pharmacy $4 for the prescription, but they'll charge back $6 for it. So the payer, if you will, the employer, is paying $6, but they only gave $4 of it to the pharmacy. So it causes what's called spread. In New Hampshire Medicaid, in talking with Mr. Lippman, that is the contractual relationship has been eliminated. However, I don't know if those in other public payers beyond Medicaid, if those spread pricing exist or not, but it's back to the same thing as being sure that people who are buying the service understand what spread pricing is all about.
Who gets the $2?
It goes back to the PBM. So that's one of the ways they make their money. They charge the pharmacy, paying the pharmacy $4 when they're charging back to the plan $6. And that's just one of the ways that they generate revenue. Any more questions about the report as far as this is kind of the skeleton of it? Are we all set with that?
Thanks for doing
All right, thank you.
it.
Thank you, Spell. So I'm going to turn it over now to Dr. Freemuth. I reached out to folks and I was told he's the person to go to, and in talking with him, I am totally convinced that he was the right choice to have for this presentation today. He's been in this field for several years. He understands it. So with no further ado, Dr. Freemuth, I'm going to turn it over to you for your presentation today.
Perfect. Thank you. Can everybody see the slides?
Yeah.
Yes.
Perfect. So good morning, everybody, officially. Just wanted to start off by saying thank you to Representative Merchant for reaching out to me and inviting me to join your board and provide you with this biosimilar overview today. One sort of housekeeping. I'm one of those presenters that is very comfortable with questions throughout the course of the presentation. So as I walk through, by all means, please feel free to ask questions when they're fresh in your mind. You don't have to wait until the end to ask any questions. So with that, I'm going to provide you with an overview of biosimilars. As formal introduction, Greg Primuth. I'm a pharmacist by education, currently a senior director for pharmacy strategic sourcing at Walgreens. I've been at Walgreens 35 years in a variety of roles. And so my role today, essentially, the strategic sourcing is around how we source and purchase brand name pharmaceuticals as a pharmacy. So disclaimer, neither I nor Walgreens have received any financial support or commitment from the New Hampshire Prescription Drug Affordability Board. Okay, I wanted to start off really with a kind of a high level overview. I know there's some folks that are much more have a lot more background in this than others, but just to kind of level set and make sure that we're all on the same level of understanding. So wanted to start out with some high levels. What are biosimilars and how are they the same or different from generics, which I think everybody's very used to and familiar with generics. So if you look at the chart on the right hand, generics are small molecule products that have been around a long time. They are well understood. They have what we call bioequivalence. So the FDA has proven that they are identical to the reference product. And so things that you think about like Lipitor and other products that are kind of small molecule tablets, they're all easily understood, small molecules. They're regulated by the FDA Orange Book, which has been around since 1980. And they're essentially identical to the trade name or the legacy brand name products. Biosimilars, on the other hand, are not identical. They are highly similar to the reference product. Biologics or biosimilars, which are related to biologics, are large molecule products, things that you think about like insulin and vaccines and Humira, high cost injectable products that are not small molecule identical products. So what they are, though, being highly similar, is that they have been approved by the FDA that they have no variance in clinical outcomes for the patients. So the biologic or biosimilars are regulated, or the reference rather is through the FDA Purple Book, which has been around only since 2011. So I think some of the comments that Representative Merchant made before relative to generics are really important comments. We're in this journey with biosimilars where we're kind of going through the same process that we went through with generics. And I think there's a lot that can be done to get this to a point that we can be much more able to save money on the biosimilars than what we are today, based upon kind of all of the regulatory and non-regulatory restraints that are out there today. So I think the big point on this slide here is that for generics, pharmacists can substitute any generic for a brand name product, any approved generic. So kind of in our triangle before, if you have two different generics for the same brand name, a pharmacist can dispense product A without approval through the prescriber. They can dispense product B. If product A is for some reason unavailable or not covered by insurance, they can move the product from product A to generic B. All of which is really helpful in terms of uptake of generic efficiency. Biosimilars, on the other hand, unless they are designated as interchangeable, which is another process which we'll walk through in a moment, biosimilars are not allowed to be substituted for the reference biologic by the pharmacist without contacting the prescriber and getting a new prescription. So that, I think, is the key difference, and we'll walk through that here in just a moment. So kind of in summary, on the left, biologics are highly similar to the reference product. Humira is the reference product. Adalimumab is the biosimilar. Biosimilars do have to have the same mechanism, same administration route, same dosage, same form, and or dosage form rather, and strength. They can have different presentations. In other words, you could have Humira 10 that is a biosimilar vial, very common in the insulin space. So as I said, biosimilars, pharmacists can substitute interchangeable biosimilars only today. However, there are state regulations out there that even put some guardrails up around their ability to do that, and we'll talk about that as well. Okay, just a real quick kind of overview of the timeline. I think it's important to understand biosimilars as we draw a comparison here to generics. So in 1984, right, long time ago, the Hatch-Waxman Act was enacted. And this is really what it allowed our country to begin to dispense generic medications. So the FDA created a pathway for generics, big savings after we navigated kind of all the pushback that was out there in the marketplace. But obviously we've come a long way today. I think over 90% of prescriptions today are dispensed are generics. Huge savings out there to the marketplace, of course. So you fast forward 26 years to 2010, and the Biologics Price Competition and Innovation Act, or BPCI, was passed as part of the Affordable Care Act. And what this was is the FDA created a regulatory approval pathway for biosimilars. There wasn't an ability to have biosimilars in the US prior to that. And they gave legacy or reference manufacturers a 12-year period of exclusivity on their biologic, very similar to what happens in the brand and generic space, so that the manufacturer that brought a biologic to market had an ability to recoup their costs and development expenses.
Dr. Freeman?
Yes, sir.
I have a question from Dr. Woodward.
Yeah, thank you very much. Is the 12-year exclusivity period separate from the patent? And does that 12 years start when the patent is awarded or when the drug comes to market?
Yeah, my understanding is it's very similar to the generic industry, where the 12 years actually starts once it's approved. If the approval through the FDA is today, but I don't actually bring my product to market for 2 years, I've now eaten up 2 years of my 12 years. Does that answer your question?
Yes, I think so. Separate from the patent is what you're saying.
Correct. It's based upon the FDA approval.
Great, thank you.
You're welcome. And for some reason, I can't see everybody. So if there's a hand up, please feel free to shout out. So a few years later, in 2015, the very first biosimilar was launched in the US. Zarzio, which is a biosimilar for the product Neupogen. So just a short 8 years ago, the first biosimilar in the US was approved. A couple of points just for reference, I think, from a dollar perspective. In 2016, biologics accounted for 28% of Medicare Part D spending, but only represented 1% of Med D volume. The next year, in 2017, there was a study that showed that biologics, now this is insulin and Humira and all the biologics, they accounted for 37% of total net RX spending, this across not just Medicare, but all plans, but only represented 2% of the volume. Today, that 37% is now 43%. So you can see the trajectory of what's going on with biologics and the cost of these biologics and why it's so vitally important for us to understand the opportunity with biosimilars, because that number is going to continue to grow at a CAGR significantly higher than non-biologics. 2021, all 50 states and Puerto Rico passed laws allowing pharmacists to substitute interchangeable biosimilars. But as I said, there's certain conditions state by state which put some guardrails on that. And then 2021, a short 2 years ago, Semglee was the very first interchangeable biosimilar approved. And as I said, Semglee is interchangeable with insulin Lantus. And so we are on this journey, and you can kind of see where we started and where we're going to. And I think this, especially in the retail space now that Humira has launched this year, you're going to see a tremendous growth in the amount of biosimilars that come to the pharmacy spend arena, with an opportunity, I think, to save significantly on costs. So let's talk a minute about what the approval pathways look like. So as I said, the BCPI was launched as part of the Affordable Care Act, and what that did is it gave this 12-year exclusivity period. So when somebody, an originator's patent expires or their 12-year exclusivity period is over, any manufacturer then can apply to get approval for a biosimilar. And so if you look to the right, the manufacturers have a couple different options. Either A, I could apply to this abbreviated 351K biosimilar pathway, and that is what is allowable to get the ability to be a biosimilar for a reference product. You could also do a traditional biologic pathway, and I put this under just for reference sake, that this doesn't actually align with the 12-year exclusivity. So as you look on this example here, so Basaglar is not a biosimilar to Lantus. It's essentially another reference or another brand product. But the manufacturer decided in 2015 that they were just going to become kind of another brand Lantus, if you will, another biologic, not a biosimilar. So on the biosimilar specific, though, the 351K pathway, this is a much abbreviated pathway compared to the reference product that had to go through much more rigorous process to get approval. And so this is the abbreviated pathway that allows biosimilars to come to market. Once they become a biosimilar, they can also choose to do additional, they can request additional approvals to become interchangeable. So,
Dr. Freeman?
yes, sir.
Oh, I'm sorry. Go ahead. I have a quick question. I think it's
Sure.
quick. On that last slide, the Basaglar, so if I, as a prescriber, wanted to write for either Lantus or Basaglar, I would have to specify, correct? And then if I wrote for Basaglar, the Lantus biosimilar, which is Semglee, would not be able to be used, correct?
That is correct.
There any, so there's no biosimilar for Basaglar. So I guess the confusing part of this would be if I were the manufacturer of Basaglar and I wanted to be competitive on price, I might try to come in lower than Semglee, but I would have to get prescribers to specifically prescribe me because I would not be substitutable for Lantus or Semglee. Is that correct?
Correct.
Wow.
So if I could follow up on that comment, from a pricing strategy, you'll probably get into this later. If I was a manufacturer of Basaglar, I would be pushing my product, not because of the price point, but trying to push them because of the other attributes of the product, competing against Lantus. So when it gets to the pharmacy, the pharmacist cannot substitute it.
Yeah,
Not-
so
You know,
I guess my comment on that is if you can think about it, so directionally, Lantus is the 900-pound gorilla in the space. I don't have the numbers in front of me, but directionally, most non-biosimilar products are written Lantus. Basaglar was much later to the game. And so Basaglar has a much smaller market share than what Lantus does. And today, well, pre-biosimilar, it very much was about trying to get formulary position, and it's more of a payer coverage conversation on whether or not Lantus is going to be covered or Basaglar is going to be covered. And then so today, to your point though, if a prescriber writes Basaglar, there is not an ability to dispense the biosimilars that are out there for Lantus. They're not interconnected.
so if I can follow through what you just said. If we're looking for rebates, if Basalar is what's on the formulary, if I get a prescription for Lantus as a pharmacist and I go to submit it for a payment, it's going to come back saying it's not on the formulary. It's going to make it more costly to the patient on the copay, which is really going to drive the business over the Basalar. And the reason why it's on the formulary versus Lantus is because the rebate could be higher. I'm just trying to think of reasons why the payer would put it on the formulary as Basalar versus Lantus.
If you have two equivalent products,
Yeah,
there's not I guess I'll frame it this way. There is not a clinical reason that one would be covered versus the other.
gotcha.
It's
Dr.
a
Wilbur,
financial
sorry.
reason.
Financial. Dr. Wilbur?
Yep.
Thank you. The biosimilar pathway, 351K, that Basaglar is or Basalar took, is their 12-year start from when they are approved, or are they are they constrained by the Atlantis initial of 12 years?
So Basaglar was not constrained by Lantus. They could do a 351A traditional biologic pathway. They're just essentially getting approved as another brand product. They're not a biosimilar. Then Basaglar has the same 12 years that Lantus enjoyed for a reference product.
But starting from their FDA approval.
Correct.
Right.
Okay, so let me talk about how manufacturers get approval for interchangeability with biosimilars. I think the big sort of the takeaway on this slide is that you have a reference product that has 12 years after FDA approval. Once that 12 years is up, manufacturers can choose to seek approval for a biosimilar for the reference product through an abbreviated 351K pathway. As we said, there's 8 or 9 manufacturers out there today that have biosimilars for Humira. There's only one that has interchangeability. It's just a bit more onerous to get approval. However, there are more coming. And I guess the takeaway there is that it just takes time to get interchangeability approval, and I'll show you why that is. So the next step for a biosimilar, in order to be considered to be interchangeable, which again means that the pharmacist can substitute it without having to go back to the prescriber to get approval to substitute. And so what happens when a manufacturer is trying to seek approval from the FDA for interchangeability is they have to go through this switching study. And so the switching study, you can see in the box there, has a lead-in period, which is the reference product. Patients on the reference product initially, they need to switch to the biosimilar. They need to then switch back to the reference product. Then once again, switch back to the biosimilar. And the outcomes have to provide the same clinical results for the patient as those in the non-switching, meaning people that have never moved off the legacy reference product. And so there needs to be no greater risks, the safety profile has to be the same, clinical outcomes have to be the same as the reference product. So this is what manufacturers have to go through to get interchangeability, which is why oftentimes you see manufacturers that will come out with the biosimilar, and then 1 or 2 years later, they'll actually gain interchangeability for that biosimilar. So right now, Boehringer Ingelheim has a biosimilar interchangeable to Humira, the low concentration version. And there's a number of the other manufacturers that have these studies going on today, and they will likely gain interchangeability sometime in calendar 24.
Dr. Freemuth, Dr. Woodward has a question.
How's the adequate washout period determined?
Great question. I'm not close to that. I could certainly gain some additional information on that and come back to you, but I'm not real close to the studies other than sort of at a high level how they work.
Yeah,
Typically, washout is based on half-life of the drug. And so it would have to be completely out of your system and no longer efficacious. So Remicade, for example, lasts a long time. Humira has a much shorter half-life. So washout is probably, I'm just guessing, but that's what we typically refer to as washout. Is that
would it
Yeah,
be the
makes-
half-life or would it be,
no, it
down
would
to
be,
three?
yeah, it would be based on the half-life.
Right, so down to 3/4 or down to
Once it's out of the system, basically,
measurably out of the
Yes.
system, right?
I would think.
Thank you.
So as the pharmacist in the room, that makes complete sense to me. Thank you for that. Okay, so those are the interchangeability switching studies that are required, again, to enable a product to gain interchangeability. So just quickly in summary, there are 3 types of biologics, if you will, regulated by the FDA. There's the originator biological product, which many people would call the brand. So when they were approved, they had to demonstrate safety and efficacy, right? They're the reference product. A biosimilar is highly similar to and has no clinical meaningful differences from the reference product in terms of safety, purity, potency, efficacy. These cannot be automatically substituted by pharmacists without gaining a new prescription from the prescriber. Interchangeable products, interchangeable biosimilars that have gone through the switching study and gained approval may be switched by a pharmacist subject to some state laws, but they may be interchanged or substituted by a pharmacist without the prescriber's intervention. And as I said, they've met these additional testing requirements. Okay, just a couple of comments, just sort of high level on biosimilars. Biosimilars have actually been around since 2007. The EU is much further along in biosimilars than in their biosimilar journey than we are. But since 2007, and then since the 2015 launch of Zarzio in the US, 40 biosimilars have launched across 12 molecules, including this year adalimumab or Humira, which is really kind of the game changer in the retail pharmacy space. As I said, biosimilars in the EU are significantly further ahead than we are. So uptake in the EU is much, much greater than the US. And I think, the US is kind of on the journey that the EU was on, but well behind them. And I think the key difference here is that in the EU, if you're a biosimilar, you are interchangeable with the reference product. You're interchangeable with other biosimilars of that reference product. There's no designation of interchangeability. So that triangle that we talked about earlier it's all connected instead of being segmented. So in the EU, there's no designation called interchangeability. They're all biosimilars, which, fundamentally acts very much like the generic industry in the United States. And then,
If I could on that, given what's happening now in the EU, interesting to see what's happening over there with risk to patients with interchangeability without going through the extra step the FDA does. Is that something that could be controlled at the state level with interchangeability, or is that something strictly controlled at the federal level?
Yeah, so great question. States do control the scope of pharmacy practice. And so I believe, and I'm not a legislator, but my understanding is that there certainly is language that can be leveraged at the state level to allow greater flexibility. Now you have to have two interchangeable products. I don't think the state can control interchangeability, but you all are the legislators in the room, but in my understanding is that there is potentially a path forward to do something much more along the lines of what the EU is doing, as long as you have biosimilars that have interchangeability approval.
Thank you.
You're welcome. So I think this last comment here that I took out of a quote from biosimilars in the United States is really important. There's going to be a lot of big launches of biosimilars over the next 5 years, right? Humira is, $20 billion a year drug. 2023 was a watershed moment for that. But you have Tysabri that just got approved, and there's a number of others that are going to follow right after. So it's really important, I think, at this point to understand the market, understanding what factors are influencing the use and the uptake of biosimilars, because biosimilars are being, thought of as a great way to generate significant savings for the U.S. healthcare system. So I wanted to walk through a few what I would call barriers to uptake today. But again, very, very important that we get a really good understanding and handle on what is, what are barriers today and how do we navigate those, because the opportunity for savings over the next 5 years and beyond are significant. So in 2020, the AMCP, which is the Academy of Managed Care Pharmacy Foundation, conducted a survey, and that survey really showed 3 top barriers to biosimilar uptake. The first one being state laws and regulations around substitution and interchangeability. The second one being pricing and contracting. And then lastly, prescribers' concerns around safety and efficacy. And so we'll talk for a minute about each one of these. So state laws and regulations for substitution and interchangeability. As we've kind of said, the designations of biosimilar, interchangeable, these are terms that aren't very familiar to many, and so they cause confusion. I think prescribers, patients, even pharmacists don't 100% understand what each of these terms means. And as I said, the interchangeability designation is unique to the US. So biosimilars are not generics, and interchangeability equals substitutable. These are things that are very unique to the US, and I think we have an opportunity at some point, whether it's a state level or national level, to do more to create designations and terminology that make it much easier for everybody involved, I think, to understand interchangeability. Is there a question? Okay. The other piece, state laws and regulations around substitution and interchangeability are all different. We have 50 states and 50 different requirements, essentially. So there's things around prescriber notifications in terms of if I dispense a biosimilar. In some states, I have to, report that to the prescriber in 24 hours. Some are 72 hours. Some you don't have to at all. It's really very variable across state. And then pharmacies are required to put specific language on the label to the patient that is different state by state. Substituted for X, interchangeable biologic product substituted for X, interchangeable with X. And so all these things really just create noise in the pharmacy world that makes it very difficult to drive a high level of biosimilar uptake. And I think the largest barrier here is what I have at the bottom. And I think that, is really germane to this discussion. Current laws do not allow substitution of one interchangeable biologic for another interchangeable biologic. And so I'm just going to talk about this for a quick second. So in Humira, as I said, there are 8 or 9 manufacturers that have biosimilars. At some point, there's going to be interchangeability broadly across those. So if I'm a pharmacy and I'm not allowed to interchange one for another, I might have to carry 9 different products in my refrigerator times 2 different strengths, 18 different products. So you can quickly see that this could become a very large barrier in terms of pharmacies being able to support substitution. These things are thousands of dollars, and you can't have 20 different variations in a refrigerator. And so I think we need to get to a point where pharmacies have the ability to use interchangeable A for interchangeable D for interchangeable C, and all that is, I think, where we need to go to from a regulatory perspective.
Dr. Premath, Dr. Sherman has a question.
Thank
Yeah,
you.
Going back to that and Senator Abbas's original question, I'm just thinking about how this would work. If we went back to Atlantis and I can't remember the names, there's, what is it? Semglee, and there's one other.
Resvoglar.
Resvoglar. If I write for Lantus, does the pharmacist have the ability to use either of the interchangeable biosimilars?
Yes.
But if I write for Semglee, then they don't have that capacity. So if I write for the brand name or the originator drug, then they have all the options available. But if I write for one of the interchangeable biosimilars, then they are limited to that interchangeable biosimilar or the brand name. Is that correct?
In today's construct, yes.
We should be able to fix that.
So, yeah, alternatively, a prescriber could write for insulin glargine, which would then also give the pharmacy the ability to dispense either the branded product or either of the 2 biosimilars.
Dr. Premath?
Yes, sir.
For the other ones on the call, I have submitted to our OLS to create a LSR, legislative service request, to try to tackle this problem. So Senator Abbas, if you have a chance, let's send the LSR your way, look at it. Because I think if you have Lantus and 2 interchangeable products with Lantus, these should be interchangeable here as well. But I think it's up to the state to create the law to allow the pharmacists to do that.
And I'm not sure if this would matter, but I think you're gonna have two situations. You have a person who is on the original biological product. And the question is, is that person, should they be changed to a biological similar at the discretion of the pharmacist if it were to become available after they've been on the original product for many years? Then the other situation we'll have is a new patient or a new person who just starts taking a medication who's never even been on the original biological product. So I don't know if we need to separate those 2 scenarios. I'll trust the doctors on that one.
Yeah.
Well, the question would be if the prescriber can designate that they have to use the brand name. The problem is sometimes that will get rejected by the carrier, correct? And they'll have to go through an approval process for the brand name rather than at least with generics, that's the way it works. If you're trying to get somebody a brand name drug and there's a generic that's much less expensive, it's likely the generic is going to be on the formulary for that carrier and not the brand name. Lipitor being an example, Lipitor is much more expensive than the generic. So it's a great question, but we'd have to look at the current RSA to see if there is the ability of the prescriber to require filling the originator drug that they're the brand name product.
The only other thing I think I wrote in my notes was, are there particular type of medications maybe we would exclude from this? And again, not being a doctor, but something like maybe like antidepressants, maybe switching from one to the other, might be a higher risk of adverse reactions that may not be apparent right away. I don't know, but
I think the antidepressants, there's no biologics in antidepressants, is that correct?
Correct.
Okay,
Not
so
being
they're
a
all the
doctor.
small molecule.
And I think part of it is that the way the generic law was written, if the prescriber writes dispense is written, then the pharmacist cannot override it. At that point in time, then it becomes a discussion between the prescriber and the payer. Because the payers can look at it and saying, it's gonna cost me this much more for the brand name or the one you want. Then you have to justify why you want that one with a prior approval.
Right.
Which slows the process down, but that's the process we have in place today. Understood. Dr. Ward?
Thank you. And just to be clear, so prescribers can also indicate reference product or branded product only in the biosimilar space. Right, so a pharmacist, again, wouldn't be able to override and dispense an interchangeable biologic if the prescriber indicated that he or she did not want that substitution.
Going back to our strategies, your strategy to reduce drug cost item.
Yes.
It seems to me, and maybe I missed it, that what we're talking about is proposing regulatory modifications to reduce. And it seemed that I didn't catch that we really are interested as a strategy on biosimilar payment modification. We're proposing regulations.
My understanding is that in order for the regulation to take hold, it has to have a law that allows the regulation to occur.
So proposing
Legislation,
legislation
which is the law.
to facilitate
Regulation.
use of interchangeable biosimilars.
Yes. As a specific strategy, yes.
We give, once we pass the law, if you will, then it comes up to the medical board and pharmacy boards to figure out how to put that law into place. That makes sense.
yes, and I would certainly hope that they would come and testify one way or another, if they can.
So would that, just so I'm clear about the goals, that would come under number 4 under goals legislation.
No, 3.
I was thinking of the section below, strategies to reduce.
Strategies, it would be a under 2
I have it as, yes.
or
two,
as a separate.
two, yes.
Probably a separate number 6 would be legislation there too.
Yeah, I think it's 6.
Okay.
Right.
Fine. Thank you, Dr. Raymond.
Yes, thank you. Okay, so barrier number 2, and I think that there is already some discussion around this, but let's dig into it. Pricing and contracting. So there are certain complexities within healthcare PBM contracting arrangements that may lead to lower uptake of biosimilars. And so the 2 examples I have here, and we talked about insulin a little bit. So the insulin glargine, which is Lantus biosimilars, have a 28% market share in 2022, which is 6 years after the launch. So even though these, a quote unquote cash price or a cost of the insulin glargine is significantly less than Lantus, after 6 years, they've only achieved the 28% market share. Insulin Lispro, which I think is Humalog, only has an 8% market share 4 years after launch. So you can see that the contractual arrangements between health plans, PBMs, and covered lives are certainly important in the uptake of biosimilars, as these 2 examples show that there's a very low uptake in this insulin biosimilar space.
Dr. Raymond.
Yes, sir.
If I could just parallel that to the generic market versus the biosimilar market. I've seen studies at which in the generic market, once a generic gets launched, typically after you get the second one on the market, the erosion of the brand name, the market share they retain is probably less than 10%. And that's all within about 12 to 18 months.
So he's saying that's not happening.
So it's not happening then, if you will, in the biosimilar space where if you look at the generic one, which is a lot more flexibility about interchangeability between the generic versus brand and so forth, because of the flexibility the pharmacist has, that in essence allows for greater interchangeability, therefore reduction of the market share held by the innovator over a relatively short period of time.
Yeah, I think that's a great comparison, Representative Merchant. The interchangeability and the flexibility for pharmacists around generics are significantly different than biosimilars. I think that coupled with, kind of some financial, economic considerations and some other considerations, prescribers and patients, et cetera, that we'll walk through in a moment. I think those things, this 28% and 8% share, as you said, if these were generics for small molecules, you'd see both of these in the 90%. Well into 90+% conversion.
Dr. Sherman?
So do we
Yes.
have any kind of breakdown in what is driving this lack of growth? That's a stark difference between the generic small molecule experience and the biologic biosimilar interchangeable experience. Do we know if it's being driven by prescribers or if it's being driven by just not enough marketing, or marketing to payers or PBMs, or what? Why would, if it's a interchangeable biosimilar product and it's significantly less expensive, this seems like it would be a no-brainer.
So I'm not sure, for obvious reasons, that I want to go down a PBM discussion. But I'll frame it like this. This 28% share and 8% share are very much driven by which product is covered on the PBM's formulary. There's a small part that's prescribers, patients, pharmacists. The largest driver of what is ultimately provided to the patient is what is covered on the formulary. I hope that answers your question.
Yeah, and so the question, I guess the follow-up question is why? What is the benefit to it? And you don't have to answer this, but maybe we can do a little digging. Why would a PBM keep a more expensive product on the formulary?
So Dr. Primuth, I think you probably set the stage for another follow-up presentation from the PBMs to why that occurs. I think that's their space, not your space, and all deference to you, but I think it's probably something we should ask the PBMs is why this is occurring. When ultimately, if we have products in the marketplace at a lower cost to the patient, why it's not happening, the patient's not benefiting from it.
Right. Or
If
the
that-
insurance,
Or
the carriers.
Carries somebody. Dr. Weber? Sorry.
So one of the issues that's implicit in here, and I don't know the answer, and excuse me if I'm out of line here. My understanding is that most PBMs have different levels of formularies where they prefer the brand names on prefer the generics at one price, but if you insist on the brand name, you end up paying a higher price out of pocket. And one question is, as the PBMs put stuff on the formularies, are they putting them on the same level, the brand and the biosimilar, or are they on different levels to the patient?
When they come to present to us, I think it'd be a great question to ask. Now, I saw something I sent to all of you folks.
Yeah.
That if there was a pharmacy, there was a report. I'm not taking away from what you're saying, Dr. Freeman, but they had on the same day 3 different price points for the same drug depending upon the plan that you were talking about, how we got adjudicated. So one went from $6 all the way to $96. So it's all over the place, but they control the economic dynamics. But that's a question I think we need to ask them and not Dr.
Is that due to like preferred rates that they negotiate with the healthcare provider?
I can send it
Yeah.
around to you. That's very interesting. Good. Dr.
So I think you've set the stage for a very good follow-up conversation with those representing the PBM industry. Just as a nugget here, I can tell you that, Humira has been a very interesting case study in 2023. Many of the payers have actually in 2023 covered Humira and one or more biosimilars at the same tiering on the formulary. So essentially the cost of the patient. My sense is that will likely change in 24 and 25 as they all finalize their strategies around what their formulary will look like. But yeah, I think that would be a great conversation for you all to have with the PBM industries. Okay, so moving on to prescribers, and this is a piece of the pie here as well, albeit I think significantly smaller. So in the study, the prescribers noted that there was economic reasons based upon their contractual arrangements with health plans, et cetera, that also limited the biosimilar uptake. In other words, there was no incremental reimbursement, and these would be on Medicare Part B, physician provided biosimilars. So there was no economic advantage to switching. Now we'll talk in a minute about the Inflation Reduction Act, which has changed that dynamic since this study came out. So biosimilar penetration rates in pharmacies have been relatively low, as I said. But looking at the examples of insulin glargine, insulin lispro. However, with adalimumab or Humira being launched this year, there's great expectation that there will be a much higher uptake of biosimilars moving forward, as many other areas I think are doing similar things to you all and trying to find ways to find these savings. So lastly, on the concerns from the study is around prescribers. And certainly, we're moving through this journey with prescribers very much in the same way we did with the generic industry in the 80s. And so there's different physician specialties that I think have very different views on biosimilars or different levels of comfort. And so some of them, they might not embrace biosimilars in the same way as others. And I think the two examples here that really kind of, are demonstrative is if you look at chronic patients in rheumatology, these are patients that have likely been on Humira for years and years and years. And in order to switch to a biosimilar, they would have to go off of one product that they've been on for, a long time and switch to a new product, which is that biosimilar. And if you think about it, conversely, with acute patients and oncology, I think is a good example. These are shorter term therapies where you might not have to switch somebody at all. You might just move them right away to the biosimilar instead of, changing them from the reference product to a biosimilar. So I think there's prescriber concerns and variations that I think will evolve over time. And we'll talk through some of these, what I think are solutions to uptake moving forward. So let's talk about some opportunities to increase uptake. So as I said, the next 5 years, there's going to be significant opportunity to save money on biosimilars. You'll see a number of different projections out there, but $180 billion is a pretty common number out there in terms of where people think this could be. Obviously, variations within the marketplace could impact that, but $180 billion of potential savings on biosimilars over the next 5 years is a significant opportunity. So there's a couple of buckets that we have in terms of opportunities to drive greater uptake. And the first bucket I have is education. As I said, the language around biosimilars is just confusing. Biosimilar, interchangeable, not interchangeable. These are all terms that are just not intuitive, and they're not well understood like in the generic space. So changing sort of the terminology to use terms like safe and effective or therapeutically equivalent to, I think would go a long way to helping drive uptake. Providing prescribers with real world experience, real world outcomes as these biosimilars are on the market for a longer time. I think there's a great opportunity to do studies to show actual real world data to prescribers about how safe and effective biosimilars are. And then, positive evidence-based communication, education materials for not just prescribers, but patients, payers. I think everybody out there needs to be educated in the US around what biosimilars are, how they're safe and effective, how we can best use them to save money. And I think education is a big opportunity, very much like what we did with the generics back in the mid-'80s. And then legislation or policy, as I talked earlier about the Inflation Reduction Act. So in October of 22, the CMS, through the Inflation Reduction Act, brought in a 2% pay increase for entities using qualifying biosimilars for Medicare Part B, and that is going to be for a 5-year period. So essentially Medicare Part B, these are not pharmacy benefit biosimilars, but physician provided. There's a 2% increase in payment to encourage using biosimilars over the next 5 years. I think we have an opportunity to harmonize our state substitution regulations. As I talked earlier, there's different regulations in every state. So doing more to kind of create harmonization and less confusion, I think would be very, very helpful. Continue to promote interchangeability approval. As I said, only one Humira biosimilar is interchangeable today. And it's unfortunately at the low concentration, which is only about 15% of the market. In 24, we think there's going to be significantly more interchangeability. And so continuing to promote and encourage that. And then lastly, which I think is the germane comment here for this meeting, is enable substitution of one interchangeable biologic with another interchangeable biologic, right? Moving from, Semglee to Resvoglar, or from adalimumab A to adalimumab B without having to go back to the prescriber to get approval to do so.
Dr. Prima?
Yes,
Chairman has
sir.
a question.
Yeah, just, I don't know if you would consider adding one more bullet, but I would put under economic, when you think of, in my experience, when I've switched patients, I'm a gastroenterologist, when I've switched patients who've been on long-term biologics or generics or brand name drugs to generics, one of the big drivers of that is I can tell them that they're interchangeable. I can use words like safe and effective and therapeutically equivalent to, but if I can lower their out-of-pocket cost, that is a major driver. Then they're willing to do it. And these are so bloody expensive. Some patients, even with insurance, they're paying a fairly high copay, or when they go to get the medications. Is that something that you've seen in the market, that these savings are being passed along to patients? And so that we can use that terminology with them, that their out-of-pocket costs will go down if we can switch them to interchangeable biosimilar.
Yeah, so I thank you for the question. I would say 100%. And I think this again is a very important thing to have as a conversation during your PBM discussion. What I can tell you is that 5 or 7% of patients today pay cash for prescriptions. And my sense is that the substitution rate for both generics and biosimilars in a cash population is pretty high, because you're saving significant dollars for the patient. There was an expectation that when Humira came out with the biosimilars this year, that there might be some formulary placement that did provide cost savings to patients. That didn't happen in calendar 23. As I said, the chairings are all the same, so there's not a lower out of pocket. There isn't a great financial or economic story to tell patients yet, but certainly the pharmacy industry anticipates and is excited about being able to save patients money through biologic or biosimilar substitution. So you're spot on. Out of pocket drives patient decision at the counter every single day.
Yeah, yeah, I agree.
Dr. Wood, sorry. Dr. Wood?
With respect to harmonizing state substitution regulations, is there or an interest group available that's proposing state regulations that could be more readily adopted across states? Or is this all state by state issues?
Yeah, I think that would be a good conversation for Representative Merchant to have with our state government affairs team. I work for Walgreens, as I said, and we have government affairs people that are sort of, state level, and then people that are at the national level. We have people that are on boards of pharmacy and work with boards of pharmacy. So I think all of those entities, along with the different professional organizations, I reference AMCP and APHA, and there's a lot of different pharmacy organizations that absolutely are doing lobbying and work to try and make this easier in retail pharmacies at some point. So I think that's a great follow-up conversation with our government affairs team for sure.
Thank you.
You're welcome. Okay, I think this is my last slide. So this is what the pipeline looks like. And you can look back to 2015 in the US, where I said that first Zarzia or Neupogen biosimilar came out. And, we have this kind of like slow growth. And then all of a sudden you get to a point where Humira is now out and available as a biosimilar. And you can see what the graph looks like going forward. As I said, Tysabri just got approved. There's a number of other really big products that are coming out with biosimilar approvals over the next 5 years. I said $180 billion savings. So when you look at this curve, the takeaway here is that it's just vitally important that we really understand all the things that we've talked about today. What is driving low uptake? What solutions can help drive greater uptake? How can we make it easier for all of the parties involved, patients, prescribers, pharmacists? And let's see what we can do to maximize cost savings in this healthcare marketplace, because the opportunity is large and not one that we can afford to pass up. And I'm happy to take additional questions.
Dr. Woodward?
The vertical axis. You've got at the top of the vertical axis 140,000. I'm presuming that's million or billion.
Yeah, I think these are billions.
Thank you.
Some real money.
You're welcome.
Yeah. Right.
Yeah.
One, just for clarification, did you say that the typical savings of a interchangeable biosimilar is 5% off the brand name price?
So most manufacturers came out with 2 price point products, 2 different biosimilar products. One of them was priced at 5% less than the originator product. I'm referencing Humira here. And so the 5%, this is again conversation, I think, for your PBM discussion. There's 2 products, and it begs the question, why were there 2 products? But there are 2 products that each manufacturer has brought forward. One is called a high WAC or a high cost, which is about 5% less than the originator or Humira. And the other is the low WAC, which is about $1,300, which I think is about 85% less than the reference product. And one manufacturer has actually come out with a product with a cost like $600.
Dr. Freeman, let me clear about this. The manufacturer, you're talking about the high WAC, high list price versus a low WAC, low list price. It's the same product manufactured by the same manufacturer, but they have 2 different trade names.
exactly. Typically what they'll do is they'll, yeah,
It almost
Sorry.
reminds me of an analogy, if you will. I remember going into a country store one day when I was young with my family, my dad and so forth. And it had a big barrel of molasses. And on one side it had the fancy and the other side they had the non-fancy, but the fancy was twice the cost of the non-fancy. I asked my father, what's the difference? There's nothing. There's nothing in the middle to separate it, but just it's perception about how people buy something.
yeah, I think that's a great example. So again, you know, typically what the manufacturers have done, they've come out with this high whack of 5% off, which has a branded name to it, right? Not Humira, but a different branded name. And then their lower whack product is actually called adalimumab. And so your molasses analogy, I think, is spot on. So there's one on the left, there's one on the right. You know, you can compare that to anything you want, right? You go to a store and someone's going to buy a pain reliever, and the trade name is on the left and the house name is on the right, and the cost difference is significant.
Just to clarify, so you have a name brand who essentially, you know, they came out with a product, they've been, you know, they have 12, 13 years, whatever it was, of their exclusive market share. And then they come out with another product that's a biological similar, but call it something different. But they still keep the really expensive one on the market.
Yeah.
But they have a biological similar also.
Correct.
So just to clarify that, is the manufacturer of Humira coming out with interchangeable biosimilars that they are now launching on the market?
No, AbbVie makes Humira.
Right.
AbbVie continues to make Humira and promote brand name Humira. AbbVie does not have a biosimilar. There's 8 or 9 other manufacturers that do have biosimilars, that are on the market. And AbbVie, of course, will continue to make and support Humira, as I would guess their market share will erode over time.
This has been really great and a lot of food for thought. I'm wondering if, I'm sure you remember back when Prilosec was going off patent. And
Yep.
I think it was Merck had the brilliant idea of introducing I think it's just the isomer, the flip, which was Nexium. They used some patent challenges to keep omeprazole off the market long enough for them to launch Nexium as a new great drug when all of us in the industry knew that it was just the isomer. Are those kind of manipulations of patent or FDA approval happening with the biologics as well?
Yeah, I don't think you'll see anything different in terms of how manufacturers look at end of product life. I think every manufacturer that loses patent exclusivity, especially with very successful products, will look for a way to continue to capture brand market share through a number of different means. And certainly what you explained with Prilosec and Nexium exists in the market today and will continue to exist.
Thank you. And perhaps I'm ignorant of this side of the business, but why would the name brand, rather than create a new product, why aren't they just reducing the price of the existing product to remain competitive? Or is that a question that no one wants to answer?
I can.
Another question for the PBM group.
PBM said, from a manufacturer's point of view, I asked that question one time with generics. Is if you have a product, it's a list price for brand name, right? All of a sudden, the generic comes available. I asked a friend of mine who was at that time in manufacturing and product manager. I said, why don't you just reduce your price? Because you got the cost. I mean, you've got the infrastructure in place. So you can play the cost game. He said, why would I do that? If I can make $100 off from something when I have 100% market share, and it only costs me $5, I'm getting a $95 profit margin for each widget. If I go into the generic market, if I only retain 10%, I still get $9 in my pocket, $9.50. In order to keep that $9.50, I have to retain 20 to 25% of the market share with a lot of work. Why would I do that? I already have a built-in market. All I'm gonna do is ride that wave down and maximize my profit margin.
So you're
Which-
selling less,
But
but at a
Higher
such a
price.
higher cost that you're, switching patients from
it's hard.
Nexium to generic omeprazole was like pulling teeth. And they just made billions off of that
Yep.
difference.
And the only difference in the drug was what they call an isomer.
It's just the flip,
So
the
left and right.
molecular flip.
Yep.
It was the exact same drug, just flipped over.
It's one thing to have to compete with, I understand when the generics come out, or I know you don't wanna call them that, but the biological similars
Yeah.
come out. But another company's making it, but they're making the biological similar themselves. So I'm saying,
No, they're not, actually. He said
that's not happening.
that Humira, the company that makes Humira is not making the biosimilar.
I'm not saying Humira is doing this,
But-
but
Oh,
But-
okay.
Dr. Primoth, can you talk about Semglee? Because Semglee is a good example of that high whack and low whack.
Yeah, so the manufacturer of Semglee, well, Semglee is an interesting case. It actually came out as a separate brand, not interchangeable until they gained interchangeable approval. And so then now there's Semglee, which is less than Lantus, but relatively in that 5% less range. They also the same manufacturer makes a product called insulin glargine. And you'll notice that they have these letters after them. It's insulin glargine YFGN, I think, which indicates that it's a biosimilar. And so directionally, and I don't have the cost in front of me, but directionally I could say, if Lantus is $350 and Semglee is $325, insulin glargine is like $100. And so the insulin glargine and the Semglee are made by the same manufacturer. One is their branded biosimilar, one is their unbranded lower cost biosimilar. Very similar to the molasses analogy.
And the pharmacist cannot substitute Semglee with Lantus because they're not considered interchangeable, but the one that's insulin.
So
Insulin-
Semglee and insulin glargine are both interchangeable with Lantus. They both got
Yeah.
interchangeable approval. But the choice of whether they substitute Semglee or substitute insulin glargine, the lower cost product, is usually driven by what's covered by the payer.
Another good conversation, I guess, with the PBM.
Yes, sir.
Gives them broad market share.
Any more questions for Dr. Freeman? I want to say this, Dr. Prima, thank you very much for enlightening us today. This is a well thought through presentation. I learned enormous amounts today. I have lots of notes in order for us to move forward on. I think it feeds in some of our strategies for next year about how to increase the uptake of biosimilars to reduce the overall cost, both for the patients as well as to our public payers.
Well, I'd like to say thank you for the opportunity. I really enjoyed coming and presenting today. A lot of great questions and things for me to think about as well. So appreciate the opportunity and wish you all great success in your ability to lower healthcare costs.
Thank you.
Thank you.
So and say that you can hang on for a few more minutes or you can depart if you wish. We're going to eventually take public comments, discuss future dates, and then we're eventually going to go into a non-public session. But right now, public comments, if there's anybody on the public. Oh, really? Oh, so you're gonna volunteer to speak for us next time?
You generate my comments. Thank you, Mr. Chair. Curtis Barry here on behalf of PCMA, which is
Yeah.
the National Trade Association of the PBM industry. And just on the last two discussions about I'm not sure I'm using the term correctly, the different products with the WAC price. And there was another manufacturer issue. I'm sure, and I've got my homework to do. I've taken back, my assignment to create some response and bring some people up at your convenience. But I'm wondering why on those last two, you're not asking to hear from the manufacturers, which is where those decisions are generated. It's the manufacturer that makes the pricing decision. And so I'm curious, maybe it's a rhetorical question, why you're not asking to hear from the manufacturers as well? Thank you.
That's a good point. I would definitely take under advice because I think we talked about that with Pharma at one time and talk about the PBMs because it sounds like both have some sort of a story to tell and to hear from both of them.
Fair enough, thank you.
Good morning, Heidi Kroll with Gallagher, Callahan, on behalf of AHIP. I just had, two comments on your, draft
Yeah.
report. One was just a typo in your executive summary. In the second to last paragraph, there's a, talk about the executive director and it says in and during September, so. And then my other is more of a broader, comment, I guess, Dr. Woodward's slide he put together. So my understanding is that all of the references to New Hampshire in here are Medicaid.
Yes,
Okay, so that it might be helpful to
Well,
clarify that.
yeah,
I was
it-
just confused because sometimes I was seeing that it was referring to New Hampshire's Medicaid prescription expenditures. And then in other places, it would just say New Hampshire.
so the answer to the ones that say just New Hampshire overall, so we're comparing overall expenditures to overall GDP at the nation, and that would be also true of New Hampshire.
Okay.
So it's
in
not,
those exam- I
so
guess-
in
I
every
guess-
slide, it's not Medicaid.
Okay, so I guess if it's all payers. Which there are
Yes,
situations where it's
Yes.
all payers, public, private, et cetera.
Right.
So just some, if that could maybe
it
going
should be
through and just
clarified.
making sure that it's very clear
Yes,
when it's
I
Medicaid.
can,
when it's
yes.
not.
I think if it doesn't say Medicaid, it's not Medicaid.
Okay.
It is. I think
Maybe we could just clarify. it.
Yes, I can-
All
I can-
payers.
I can go through and check to make sure it's
Okay,
clear.
yeah, I think just being clear when it's just Medicaid or.
Say
being
all
very clear
payers.
it's all payers.
Yes, I can do this. Good point. Thank you.
Any more public comments? Okay, anything on the Zoom at this point in time from the public? Everybody out there? No hands up? Awesome. All right, so in saying that, I'm going to talk about future dates for the board. We have one coming up on October 16th. And at that point in time, it will open in public, but we'll go into non-public to have interviews with candidates. The next one after that will be October 30th, which will be the time we'll go over the final report of the annual report, sign off on it. And after that, I don't know what we wanted to do as far as meetings. So
Would all those be at 9:30?
9:30. Okay.
I'm gonna keep them at 9.
Yeah.
The,
Then I'm here
I've
at
got on the
9:10.
16th.
Something
I've
that
got
was-
a
Dr.
conflict.
Sherman called me, let me know he's gonna be 10 minutes late. He had it down as 9 o'clock. He's actually 15 minutes early.
20.
20.
I wouldn't have told him we got it.
Yeah, you blew it.
So what do you wanna do for the meeting? You wanna meet again in November, or do you wanna skip November and go into?
It was the 16th at 9:30 and the
30th,
30th at
9:30,
that was so that just changes the time, right?
correct. So then as far as going into November, we're gonna run into Thanksgiving. I don't think we have to meet 2 weeks after that. We're meeting on the 30th. I'd like to probably do it maybe on December 18th as one last meeting for the year. And then at that point in time, decide what we
When is
wanna do,
the annual report due?
November 1st,
So we're gonna vote on that on the 30th.
30th, we'll finalize it.
Can I ask one other question? Or just,
Sure.
I don't know when, my term ends, I think, at the end of October, so. I don't have any input on this, but generally attendance is better in the November meeting than the December meeting. Just because of holidays.
Holidays. could meet on the 20th, that's gonna be 3 weeks afterwards. Yeah, that's kind of early. Thanksgiving weekends, that's gonna be tough. And the following week, I'm gonna be out from the 26th of November through the 10th of December. So we can meet on the 11th
I'm traveling from the 30th. Just for a couple days,
of November,
30th of December,
in December, yeah.
Maybe we should do the 18th of December.
I can go the 18th is a possibility. Does that work? Back forward, December 18th.
December.
And maybe by that time, the mayor will have his constituents and so forth all lined up possibly for a presentation about the PVM world, and we'll follow it up with pharma.
Happy to
That
accept
works,
that.
okay.
Yes, yes.
18th at 5:30.
At 9:30.
in November, are there any,
No,
nothing?
You're anticipating offers to candidates at the end of October, correct?
hoping, no. Yes, we're hoping to have the finalist to be announced on October 30th. The interviews will be on the 16th. So we're gonna go through the ranking today in non-public. And then based upon the rankings, then at that point in time, extend either 3 or 4 for interviews on the 16th.
And then make a decision on the 30th.
Gonna make it on the 16th.
Okay.
So they give them time for the people.
It says 16th is pretty much all non-public.
Well, we will open in public,
Right, no, I
and then
understand.
we'll move into non-public.
The October meeting, I'm gonna have to Zoom. Prior.
On the 16th?
There isn't a Zoom option, is there?
No. Sorry. That's because of the confidentiality.
Yeah, I understand what you're saying.
Yeah.
I will see what I can do.
I have another here, commission on the 16th, yeah, I think it's at 1. I gotta make sure. I may have a conflict. But I'll be in the general area.
Okay, I think we could start at 9. I mean, it hasn't been public notice yet. Or do we-
It has, yep. I think all 3 I haven't noticed publicly, but
Oh, by chance.
You can
We
notice
can
a
always
change.
change.
so we're.
Would starting early in the morning, would that be helpful? I mean, I'd do it.
If we're interviewing 3 or 4 people. And then make a decision, I don't think we'll need. Till 2:30.
It'll be started. I just think it was something that happens.
Start at 9.
Start at
and
9,
Finish at 1.
which should be done by 1.
I'm gonna, if you give me about 15 seconds, I'll give you.
Okay, all right. Thank you. So possibly.
Yeah, the other one I have is, it's at 10 AM. So I'm not sure if the 9 and 9:30 would really matter.
At 10 AM.
That's the commission to study the impacts of the Secured Youth Development Center. So they'll be taking a vote that too.
So main thing is we have a quorum.
Forum, that's gonna be. Senator Rosenwald and Mr. Fahey, Attorney Fahey. What's your flexibility on October 16th?
He's muted.
Attorney Fahey, I think you muted.
He did put something in the chat that maybe he said he got like 3 that day. Should we try to find that?
Representative Edwards is not on.
Representative Edwards is also on that commission that I'm on.
So it won't be here.
Well, one or the other, right?
Yeah.
Are you gone that whole week or just
No.
Monday?
It is, a general meeting. I think it's in Durham.
that commission, and again, I'm not the chair of that commission, but I would say that the meetings are usually less than 2 hours. So I don't wanna push everyone to the afternoon. Seems like you guys like to be out bright and early, but
We had switching to Tuesday, the 17th.
I could do
Worse for me.
worse.
In the morning, the afternoon's wide open.
What about the 17th for you?
schedule. But I'm saying the 16th, and just move it to the afternoon, maybe 12:30.
Yeah, I have something at 2,
Two.
16th. I
That's
would
on the
miss it
17th.
for this.
I don't know what everyone else.
Well, the most important thing at this point is to have a forum.
Or, yep. So. We could stay at. Which time do you mean, 10?
It's at 10 o'clock.
If we met here at 9. Then we just have to get a quorum.
We won't have as many people here as possible.
This. Attorney Fahey, are you out of the country all that week?
I am. Can you hear me now, Mr. Chairman?
I can hear you now.
Yeah, I am, unfortunately, and I obviously can't be in attendance if I'm not out of the country.
Correct. Senator Rosenwald,
What?
on October 16th,
Are you free?
Yes,
you-
I'm available.
we're in person,
Yep,
so we can start earlier, that we can get you.
Well, I'm gonna come here and then just leave, so that's kind of just a formality. I don't.
Are you available all day that day, Cindy?
I think so. Yeah,
What time are you done?
I believe so.
Estimation? If those meetings would you go no longer than 90 minutes?
So,
I would be guessing, but I'll be at the State House, so I'll be coming.
So
near.
we would have. Are you free in the afternoon on Monday?
Yes, I mean, I'm just gonna have to skip this other thing. I don't have hours.
And I assume Representative Edwards, I don't know his schedule, but he's gonna be at the first one. We're on together.
12:30 and 1 to 5.
what time are you here? 5, that can work.
I work till 4.
Okay, 12:30 to 4.
Are you here?
I can be here.
Okay.
I'm unclassified, so I.
Well, flexibility, okay. Let's shoot for 12:30. And then go for what we need to do. That way there, Senator Abbas and I think Representative Edwards. You can,
I can be,
You can be-
I'll just cancel my.
Okay. I can be here.
Yeah.
Yeah, okay. So make it from 12:30 to 4. We'll work it out. We'll just change the notice. On the calendar.
We'll
get that out. And then as far as, so we got Senator Rosenwald. Dr. Sherman. Dr. Woodward, Senator Abbas, Representative Edwards, myself. That's probably the bulk of it right there. Okay, all right.
One other question is the meeting on the 23rd, on the
30th. Yes,
I'm probably gonna be back in town, but.
that will be a Zoom. So
That's okay to
Yeah,
Zoom?
yeah.
Okay,
the one on the 16th, it has to be in person because of the interviews.
right, all right.
It's 12:30.
12:30 to
4.
4. That's the intent. Then we have a backup. If we need one.
Probably make myself here.
Then we get the all right. We're all set, so I'm gonna have to ask for a motion, please.
Move to go into non-public.
Okay, for RSA 91A32B, is there a second?
So moved.
So, thank you. This does require a roll call vote, and I will call the roll call for the ones that are here today. Dr. Woodward?
Here.
Yes.
Yes.
Dr. Sherman?
Yes.
Senator Abbott?
Yes,
Attorney Fay,
Yes.
Senator Rosenwald,
Yes,
is there anyone that objects to it?
Would be glad to receive any more.
Hearing no objection, the majority of the board having voted yes, we will now go into non-public session. For those who are in the public, we will come back out briefly, but there'll be no business to adjourn. Okay, right.
If I can ask one informal question, Dr. Sherman, do you prefer to be addressed as Dr. Sherman or Senator Sherman?
He you works. You can call him either.
Bunch of
Stacy
one, they say it's a lifetime.
It's a lifetime.
That's what Judge Lane, Bob Lane, Representative Lane, same
Right.
problem.
No, you're right, and